Started. So without further ado, I'm going to turn over the floor to our quizmeister in chief, Al Lewis. Most of you know Al. Al is regarded as one of the foremost authorities on wellness outcomes. He's written several books about it. He's also written books with Tom Emmerich, who managed benefits at Walmart, and back in 2013. Walmart did many of the innovations that have gone mainstream, and part of that book was actually about managing pharmacy benefits. So without further ado, here's Al Lewis to lead our discussion.
Thank you very much, Mark. So first, let me introduce our partners, one of whom is having some technical difficulties, but one of them is right here. This is Zach Robinson. Zach is the CEO and I believe founder, Zach, correctly, of Disclosed RX?
A co-founder, but yep.
Co-founder, yes. And Disclosed RX, and this one, when the history of GLP-1s is written, it will be noted that they are the first PBM where the light bulb had gone off to say, let's partner with Quizify and figure out a different way of getting people on these, educating people about these drugs than traditional pre-authorization. Our second partner is Paul Holmes, and he's having, like I say, a little bit of technical difficulty here. Mark, you're not seeing any updates. Has he been able to jump on?
Not yet. No, I'm trying to ping him.
All right. So he is very well known in the PBM industry. I'm not saying they're necessarily very fond of him, but he is very well known in the PBM industry as probably the leading employer centric expert on the contracting, auditing, and monitoring of PBMs. They have plenty of attorneys on their own. There are very few on the other side, and he's probably the best known one. So this is the 5 things. Number 1, the savings nowhere near offset the costs. Pre-auth is easily gamed by employees and doctors. Many PBMs make more money if more GLP-1s are used, and they figured out ways to use more GLP-1s. The downsides don't get much attention. And while a lot of people are looking at coaches, coaching coaches people to stay on these drugs when maybe they shouldn't be. Or as you'll see, maybe it's an incomplete solution. And unfortunately, there is a path forward. And we'll show you that last. Well, let's go to the savings being nowhere near the cost. And let's take a look-see at the weight loss drug economics calculator. If you want this, you can ask for it. Frankly, we're not going to guarantee we're going to send it to you free. It will depend on your organization. But we probably will. You can enter whatever you like in the assumptions, and it will spit out what the cost will be from the drugs. So we're doing this on a per thousand basis. Then you've got your obesity rate. You can change that to whatever you want. And then, and this comes from the literature, the percent of obese people who are eligible, indicated, and interested. Then there are going to be some that drop out regardless. And when we talk about savings that are attributable to Quizify or coaching, we don't want to count the ones that drop out regardless. As the analogy that I sometimes use is, if there are 100 coins that are turned to heads, and you tell me that you can change 50 over to tails by flipping them up in the air, I'm not impressed. If you tell me you can flip them so that 60 turn out tails, number 1, I'm impressed, but number 2, I only give you credit for 10. So likewise, a solution that we come up with would not take credit for the ones that would drop out anyway. Then we want to talk about the cheaters. And there's a lot of cheating going on, as you'll see, and we've got the data on that actually. The cheating makes a huge difference. These are people who, those of you who recall the old days of outcomes-based wellness probably remember that you were either fined if you didn't lose weight or you got some big incentive to lose weight. So people would go gain the weight in order to lose it again. Well, now they only have to gain the weight. They don't have to lose it, number 1. Number 2, the incentive is not $500 or $1,000. It's you get this drug that it costs the employer possibly $10,000 $10,000 a year. But watch what cheating does. So right now we're guessing that 3% will cheat to reach the 30 BMI. Remember, the average US BMI is about 29. It doesn't take a lot of cheating to get there. And we have heard anecdotes of people, putting ankle weights on and that kind of thing, which also used to happen during the days of wellness. So with these assumptions, the annual cost of your drugs per 1,000 people is $847. As you'll see, there's actually very little reduction to be had in medical claims and other drug use. And you might say, what? I thought there were some offsets. No, not a lot. You'll see in a minute. That gives you a net cost per thousand of $809,000, which increases your, if you start with $10,000 a year in health spend, this will increase it by 8%. 800,000 is 8% of $10,000 a year times 1,000 people. So 10 million, that is. So you get an 8%. Now, as you'll see, if you do Quizify, and this is not an ad, but we'll show you this a little bit later, that 8 falls to 5 at a minimum. Now watch what happens if you increase this cheating number to 6. It makes a dramatic difference in the overall spend. You cannot eliminate cheating, but if you did, it would actually make this fairly, affordable in the overall scheme of things. That's still an overall 4% increase in total health spend. The cost of the drugs, and actually we should probably net this out of, Zach, what would you say it would be a net of rebates, maybe 8,000 a year, something like that, 9?
I think that's pretty close, Al. It varies drug by drug, but at 8,000 a year is pretty close.
All right, we'll call it 8,000. So, it's not this humongous expense, but you figure your healthcare spend is going to go up by 6 points a year. Well, suddenly it's going up 10 points a year. That is a huge difference, even though this looks like a 4. Remember, it's a 4 on the total spend. Now, you're not going to have employee co-insurance and copay. That actually increases it if you take out the co-insurance. Now, we said before that there's not a lot of savings from event and procedure reduction. This is for the weight loss drugs, not diabetes, the weight loss drugs. Let me just see if this is is he able to? Oh, here he is. Hey, Paul, you in? I think he's muted, but he's coming in. So there's not a lot of reduction, even if you take the literature, which says there's a 20% reduction, and we do have 20. We attributed 10% to the drugs, 10% to the coaching. There's very few risk-sensitive events in the under 65 insured population. So there's shockingly few heart attacks and strokes in people under 65. And people think, oh, there's a ton of them. Yeah, maybe in the days of Mad Men there were, but there really aren't anymore. It's something that hits older people harder. So you got that, but then you say, well, wait, that's the entire under 65 population. What about those who are obese? Taking out the diabetics, for which these drugs may make some economic sense, and they certainly make some clinical sense. But so let's multiply that by 5. Let's say that it's 5 times as likely that someone who's obese and not a diabetic is going to get these events, and that is not the case. And those of you who are familiar with Marshall Allen, who just shockingly and distressingly and tragically died of a heart attack before age 50 this week. He was a major contributor to this industry and a good friend of mine. These events tend to hit fairly randomly under the age of 65, and his, unfortunately, is a good example of that. Then we throw in the cost per event. So you do all this, and these are very, very generous assumptions. You still only get a small reduction. The bottom line is these are expensive drugs, and nothing is going to offset them. And by the way, this is all assuming that all these reductions happen in the first year, which they don't. But we're trying to be very generous to show that essentially nothing has happened.
And Al, I do think that's very conservative, because I just saw another study that came out just the other day that showed that plans that introduce GLP-1s saw a $1,400 per member increase in costs in the first year, no cost reduction.
Yeah, I'm shocked it's only $1,400.
Yeah.
Yeah, I'm sure that probably includes everyone who did it for a month and then dropped out, kind of thing. Yeah, because if you did this over a year, you're way over 1,400. Um, we can get to the savings here. Now, what we do at Quizify is we make them take a quiz, a sort of, we call it the Curb Their Enthusiasm quiz, that encourages people to know about the side effects of these drugs, the downsides, everything they need to know. And some significant number of people are simply not going to pass or finish the quiz and go on to the drugs. And that's where you get the difference here. But this is not an ad, so we'll send you this model and you can look for yourself. But it's a humongous difference spending a little bit of extra money on the quizzes. All right. Well, I said before that the pre-auth is easily gamed and that people cheat. And let's look at that actually. So pre-auth works where patients can't game the system. So this is a knee, a torn meniscus right here, which is what I had. This is actually not my knee, but you can't cheat your way to physical therapy. You can't cheat your way to an orthopedic surgery. There has to be an image that goes with it. And that's pre-authorization works when patients can't game the system. On the other hand, you can binge your way to a 30 or 35 BMI if you want these drugs. And this is 6 common conditions. This is a real group, big group, that has prevalence of these conditions. And this is the change in prevalence from when they introduced the GLP-1s for weight loss. So 5 of these 6 conditions essentially stayed the same, went up, went down slightly. Obesity as a diagnosis skyrocketed, even though the population of the US is getting maybe 0.5% more obese every year. Suddenly they were getting 9% more obese. People will cheat. That's why, the PBMs, the carriers have a certain hammer that they call pre-authorization, and they're trying to apply it to a nail that it simply does not work here. Now, Paul has joined us, so we want to hear from our special guests about how PBMs don't have the same incentives that you do, and not all PBMs. We wouldn't be having Zach on if he weren't, one of the good guys, right? So I'm just going to set this up, and then we're going to turn the floor over to our guests. So there is a rebate that pharma is offering. And those of you who recognize this from high school, this is supposed to be the old man of the sea, Santiago hooking the bonito here. The thing is, before he gets back to shore, the middlemen are taking a piece of this bonito. And by the time he gets back to shore, it's pretty much all eaten. And that's sort of the tragedy of the book. So I'm going to turn, and Paul, we already gave you a really nice introduction. So I'm going to turn to you first and say, so tell me what, like, the 3, well, let's start with it, say the 2 biggest things that PBMs do that, don't benefit the employer, but benefit their shareholders. You're muted.
Can you hear me now?
Oh, yeah.
Okay, thanks. Sorry about that. My dog was barking. That's why I muted myself. Sorry about the technical difficulties here at the beginning. Really glad to be a part of this. I think Zach will appreciate this. Well, everyone should appreciate it, but I think the easiest way for me to weigh in on this subject is to just give you a real life example. I won't mention any names, but I have a pretty good sized client right now that is fighting with their PBM over the fact, and this is one of the large PBMs that everybody has heard of, because this particular employer with over 20,000 lives doesn't cover weight loss drugs. They've never have. It's clear in their plan documents. They do cover drugs for type 2 diabetics. So if a GLP-1 is prescribed for a type 2 diabetic, that they will cover. But if a GLP-1 is prescribed for someone who's not a type 2 diabetic, they will not cover it. But notwithstanding that clear coverage provision, their GLP-1 spend went from, I think I'm going to use rough numbers. I think it went from 1 million or a little over a million a year to 4 million a year over the last few years. And their number of, I can't remember if this was total GLP-1 users or maybe it was total Ozempic users, but it went from 110 to like 600. And, they hired me not that long ago, and I was looking at this and I was saying, well, geez, your GLP-1 spend looks like it's really skyrocketing. Are you hiring a lot of type 2 diabetics? And, I was only half joking. So they were not aware of the issue. Their PBM had not brought it to their attention. Their large consulting firm had not brought it to their attention. But when I brought it to their attention, they immediately said, wow, we're not quite sure how this happened because we don't cover weight loss drugs. So we quickly requested the prior authorization protocol from the PBM to see whether they were screening these drugs and only approving the claims for type 2 diabetics. And we found out that the answer was no, they had not been screening the claims for type 2, but they were willing to do so. So we asked them to start doing it. And of the first, I won't go into the whole story, but basically there was a group of, what they did was when they set up their prior authorization protocol, they said, okay, from now on, if you want a GLP-1, you're going to have to show that you're a type 2 diabetic. However, we're going to have two exceptions to that rule. And the exceptions were created by the PBM to allow as many people through the gate without having to show their type 2 diagnosis. So it was things like, if a patient had ever been on metformin for at least 30 days in the last 2 years, which is a very common, I'm not a doctor or a pharmacist, but it's my understanding that metformin is very commonly used. It's used for pre-diabetics. It's used for people who are trying not to become diabetics. And so it's a very common, inexpensive, effective drug. And more than that, it's easy for someone to go get a metformin prescription and be on it for 30 days. They don't even have to take the drug. They just have to pay for it for 30 days and then apply for a GLP-1. And under this PBM's protocol, that would get them through the side door. So in essence, the PBM created a prior authorization protocol that had no teeth, which is appropriate for this shark picture. It had no teeth, and so when they actually applied the test, I forget the exact numbers, but it was something like of 220 people that they asked for type 2, documentation of type 2 diagnosis, they got 15. So I don't know what that math is, but it's less than 10%. Less than 10% of the people who were finally screened for the first time could show they were diabetics. The other 90% were just getting the drug for weight loss under a plan that doesn't cover weight loss drugs. So bottom line is, good story for PBM or for plan sponsors. Go check your prior authorization protocol on these drugs and see how tight or how loose it is.
If I could add to that, and then I'll turn to Zach. Paul, you missed your intro here, but PBMs have armies of attorneys drafting these contracts and defending them, and Paul's really the only guy of stature who's on the other side here. The David fighting the Goliath. So if you have issues with a PBM, he's the guy to call. Zach, did you want to add anything? I mean, I'd like to add something, but you're a special guest, so you go first.
So two quick things, Al. One, I always look at Paul as Leonidas in the movie 300, right? So uh, he's the guy who's just taking everyone down. Love the work that Paul does, but yeah. So I think there are a lot of misaligned incentives in regards to GLP-1s as a category, specifically, as it relates to weight loss drugs. Like you said, we've experienced cheating in member populations where our plans are covering weight loss drugs. The rebates, those almighty rebates, are a huge incentive for PBMs to want to cover more of those drugs because they're keeping some portion of that rebate. When you remove those misaligned incentives, those typically tend to level out a bit. And then, lastly, I think that this example is very appropriate, right? I mean, a lot of those rebate dollars either are getting taken by someone else, or when you assign a present value calculation, at the end of the day, really come out to be, the juice is not worth the squeeze.
And Paul, you and I had talked offline about you remember the old Frank Sinatra song "All or Nothing at All," where there are PBMs that are saying to their big accounts, if you don't cover these for weight loss, we're not going to just do it at all. You either have to cover it all or not cover it. Am I getting that right?
Well, close. What I've seen now, in only a couple cases, and I haven't figured out if this is much more widespread yet, but for a major client, a major PBM told them that they too wanted to impose a type 2 diabetes, prior authorization requirement to make sure they were only covering the drug for diabetics, because that's what it's approved for. And the PBM told them that if they wanted to impose that common sense type 2 screen, that they would lose all rebates on all GLP-1s, even the GLP-1s that were dispensed to obvious diabetics. So it was a threat that if you want to do this, you're going to lose all your rebates.
And Paul, I've got a pretty big problem with that.
Yeah, that's what I. I was just saying that's what I meant by the all or nothing at all. I got it wrong. No, that's exactly what I saw. Yeah, Zach.
I've got a pretty big problem with that because Paul, I'm sure you've reviewed, many SPDs in your career. I'm fairly certain that every SPD, when you get to the pharmacy section, says that the plan's not going to pay for non-FDA approved medications. And so when you're taking a GLP-1 for a non-FDA approved indication, now the plan is on the hook for that, right? And now it becomes a fiduciary question.
So let's. I hate to sound like a cliche, but let's put that in the parking lot because
Sure.
there is a very specific place where I want to come back to that.
There is a question about the magnitude of rebates. Can someone provide an example of just how an idea of what the rebates may actually be on a drug that can be $8,000 to $12,000 a year?
So, I mean, it's going to vary a lot depending on what drug it is, what channel it's filled through, things like that. I think a good rule of thumb is, and so the 8,000 a year was post rebates, right? So somewhere around $4,000 a year of rebates, which imputes an initial cost of $12,000 a year waiting for those rebate dollars.
And I would add to that, there is a publicly available document, we're not mentioning names, where a state entity disclosed what its rebates were and got threatened. Remember, it's a state entity. Clearly, something could be FOIA'd of this magnitude, but they were forced to redact the actual number on the rebate. So this industry is, and Paul, and Zach, I'm not telling you already things you don't already know, but this is a very sort of not a transparent, even after the laws that say it has to be transparent, it's still a very opaque industry.
Yeah, I mean, in the client situation I just mentioned, I said to them, even if the PBM is telling the truth, which I have some doubt about, that you're going to lose all rebates, I said, if you can knock out 80% of this spend or 90% of the spend, then who cares whether you get a rebate on the other 10%?
Right. And that's a great segue into what actually Quizify does. So people are getting their information from influencers who are so strongly in favor of these drugs because they're getting paid that TikTok just shut them down because they weren't disclosing their contract. Literally within the last few days, shut them down. The downsides don't get much attention. The cancer, the pancreatitis, the stomach paralysis, the gallbladder, kidney issues, maybe nausea and vomiting gets some. The constipation is actually much more serious than people are saying. Quizify covers all these things in the Curb Their Enthusiasm quiz. These plus much more, yada, yada, yada. But here's the thing. You can't yada, yada, yada the label on these drugs. And this is the parking lot that we were talking about, Zach. These drugs are an adjunct therapy, according to the label, to be used in conjunction with diet improvement and exercise. So I would ask you too, both of you, that it seems, and I just came up with this like last night, so I could be way off here, but it seems like if you are not doing these according to the label, you as a plan sponsor are violating your fiduciary responsibility.
I'll leave it to you on the legal side, but I mean, I assume someone could reasonably make that argument.
Well, yeah, I mean, I'm not, I don't want to quite go all the way there, but I would say that, plan sponsors, in my experience, are basically giving the keys to the PBM and letting the PBM decide who should get the drugs, and that's a big mistake. And at a minimum, the plan sponsor should be having a clinical expert review these protocols to make sure that the PBM is only approving the claims that are clinically appropriate. And if the label says that this is a drug that needs to be used in conjunction with diet improvement and exercise, then that should be part of your prior authorization. In other words, it should only be approved if the participant can show that A, they're diabetic, and B, they're involved in some program involving diet improvement and exercise, which is not that hard to check. And I think that's where the Quizify program sort of comes in.
Precisely. This is our business model right here, is making it very easy to check whether people are learning the stuff or not. Now, a lot of people use coaching because that's the hammer that the wellness industry, that the diabetes industry has, is coaching somebody on changing and behavior change and sticking with the drugs and not doing stress eating and a whole bunch of other things. I'm not I'm not diminishing that. I mean that is a thing. I mean some people do benefit from the coaching, but if you coach somebody to jump into a pool, in this case, coach somebody to get on the drugs and stay on the drugs, and you want to coach them how to improve their improve their lifestyle, it's not enough to say improve your lifestyle. If you coach somebody to jump into a pool, you better also teach them how to swim. And that's where Quizify comes in. We fit that little gap here between coaching people, and it doesn't do any good to coach people if you don't know, if they don't know what to do. If the coaches often don't know what to do here, they tend to flunk our quizzes, as we've learned fairly recently. U.S. Preventive Medicine is our go-to coaching partner, and they do not flunk. They've memorized all these things. And Disclosed RX, as mentioned, is our first PBM partner and also a fiduciary PBM. And I think if we have time, we'll get into what that means. So the question is, do coaches even know how to swim? And now we're going to go to a question. And while you're doing the polling, I noticed that our Q&A box is filling up here, Mark. So let's ask the question first. And about 20 of you were on the webinar we did in January on nutrition. So you're going to find this fairly easy, but the vast majority of you are, it's a new question. A zero nutrition fact of which of the following indicates that a food is at least probably healthy. Cholesterol, trans fats, both or neither. And Mark, let's see if what we got in the question box.
Yeah, we had, I think you may have touched on this when you were going through the calculator, because I know there's a section on it, but what do you use to calculate the medical savings when using a GLP-1?
All right, we will, whoever asked that, will send you the calculator, and it's sourced to a study from Novo Nordisk, which I think is number one. We're very generous about it because we said the savings take place in the first year of use, which they probably don't. And number two, you can change the assumptions all you want. We might as well do one more question here, Mark, because we are getting backed up.
Thoughts on ordering GLP-1 meds from Canada? Does Disclosed RX offer international prescription fulfillment?
Yeah, absolutely. And that's one potential channel. There are several others that we can use to bring the cost of those drugs down that avoid rebates, and you not have, be paying less out of pocket up front, not having to wait to get those rebates back later. But especially branded medications, they're patented. They come from the same manufacturer. So whether you get them at a pharmacy in Canada or your local Walgreens, it's going to be the exact same drug.
And Mark, what do we have? Oh, this is a very smart audience.
Yeah.
Yes, it is, in fact, neither. So let's do the trans fats first. The trans fats should not be on the label at all because I don't know if you've noticed this, but they're always zero. And the reason they're on the label is because the food industry lobbied the FDA to keep them on the label because I know people are looking at the label and they're going to think something is healthy if it says zero trans fats on it. And actually, there can even still be a trace of trans fats in there and just rounds down to zero. So it's completely misleading. Now, as for cholesterol, if you see a product that screams contains no cholesterol, cholesterol free, I will bet you whatever that is full of sugar. And this is an example. This is from a cereal. I don't remember which one. Cholesterol. Oh, it also says what good sources of vitamins. And, one of the things that we tell people is for everybody who has a clinically significant vitamin deficiency, there are 10,000 people who get too much sugar. Okay. That's not exactly, if anything, that's an understatement. So you can see that here. All right, let's do another one. The first ingredient in a Cliff Bar is organic brown syrup. Organic brown rice syrup, which are true about that, is an excellent way to naturally sweeten a granola bar. This is as bad for you as sugar. The fiber in brown rice syrup aids your digestion. Because it's organic, some antioxidants are preserved. And Mark, we still have a backlog here.
Okay. I've heard you answer this before, Al. What was the whole genesis of the rebates? Why do they exist at all?
Oh, you want to do a whole nother webinar here, folks? The reason is that there are two components to an employer's medical spend. There's admin, which is like this much, and medical spend, which is this much. So most of it is medical spend. Now, the cost of the drugs hits the medical spend, and for some reason, most benefits departments aren't really gauged on medical spend. That's considered to be uncontrollable. The rebates hit the admin line, and benefits folks love it when their admin line declines. So PBMs essentially know they can get away with whatever they want on medical as long as they do this little rebate thing in the admin. Okay, Mark, what do we have? Oh, wow. Okay. Good job, everybody. The question is, would your employees know this? And I think part of it is contextual. Obviously, we're not going to ask the question if that's not the answer. But if you look at this ingredients label, you can see that it's not, anytime you see the word syrup, it's sugar. It doesn't matter what the words are before it. You see other sugars in here as well. Cane sugar, I don't have to go through them all, but these granola bars are candy bars. Unfortunately, there is a path forward. In the immortal words of the great philosopher Yogi Berra, if people don't want to come to the ballpark, you can't stop them. Okay, so the idea is to keep people out of the PBM's reach altogether. And we've kind of hit on this a little bit already. Your PBM contract cannot, sometimes they say, and Paul, correct me if I'm wrong, that you've read more contracts than all the rest of us combined here. Sometimes they say that you can't do pre-authorization, that they do all the pre-authorization.
Yeah, most standard PBM contracts essentially read that, that the employer hereby is in signing this contract, the plan sponsor is agreeing to allow the PBM to implement its own prior authorization and step therapy protocols. So
Yes.
Exclusively.
if you don't modify that language, that's what you've agreed to.
Right. And the beauty of these questions that we're asking is your PVM contract cannot prevent you from encouraging your employees to self-pre-authorize by learning about these drugs. And we start with this Curb Your Enthusiasm quiz, where we have this 24 question set that talks people off the cliff who likely would have failed anyway, because you do want to cover these for some small portion of your obese population, the ones who are serious about losing the weight and maintaining the weight loss. You just don't want to get the casual people who are going to drop out in a couple months. And this would be a sample curb their enthusiasm question, which are true about Ozempic face, which is the risk of your face getting wrinkly after losing a lot of weight quickly. Unlike Ozempic, newer drugs don't cause it. It's not caused by Ozempic. It usually goes away if you keep the weight off. It almost always goes away if you regain the weight. And I think we're catching up to our backlog. But what do you have there, Mark? Anything?
Sorry,
Think
we
you're
got the air show flying over my head that's coming up this weekend
Oh.
here. It's another question for Zach about international. Is Zepbound or Wegovy available via the international purchasing route?
I believe so. I don't know specifically, but I can check and get back to whoever answered that question, of course.
And Mark, what do we have?
Okay.
Actually, this time we stumped the panel almost. In fact, Ozempic face is not caused by Ozempic. This is a myth. And by the way, it doesn't almost always go away if you regain the weight. It does if it depends on your skin quality and your age and that kind of thing. But any rapid weight loss causes it. And the thing is, rapid weight loss is much more common if you're using one of these drugs. We do say in the official answer, by the way, that this photo was probably photoshopped, and because we don't want to overstate our case. Nonetheless, some number of people are just going to see this one question out of 24 and say, okay, I'm done. This is not worth it to me to take that risk. So the typical approach to do this is use a non-transparent, non-fiduciary PBM. You use the traditional, that as Paul said, you're often usually required to do, easily gamed pre-authorization. It's sometimes very expensive and extensive SEP therapy, as Paul said. You may not be paying for it separately, but trust me, you're paying for it. And then they use the typical coaching. And what we're looking at is using a transparent, perfectly fiduciary PBM. And Zach, if you want to comment briefly on difference between transparent and fiduciary, that'd be great.
Yeah, so I mean, transparent is a word that has a definition in the dictionary, but not defined as we talk about healthcare specifically. Full disclosure, fiduciary, those are terms that have set definitions that apply across any industry. And full disclosure means that all parties to a transaction have all relevant details about that transaction and it's verified by an independent third party. Fiduciary, there's a couple of elements that determine who is a fiduciary, what a fiduciary does, and because we already act that way, we have taken on that moniker. Full disclosure is how the company started, and we act as a fiduciary because we're free from any financial conflicts of interest and several other things. And so that's that's what we do, is we make every decision in the best interest of the plan sponsor and plan member.
You're a privately held company. Paul, could somebody do that if they were a publicly held company with shareholders? Could they be a fiduciary on behalf of the employers?
No, I don't think so. I think all the large PBMs have very clear language in their contract saying that they will not accept fiduciary status. I mean, there's a limited, in some cases, there's a very limited piece of what they do that they'll say, okay, we'll be a fiduciary for just this one thing. But for the most part, they will not accept it. In fact, they have language now in their contracts which says that if you there are a few states out there that have passed laws saying that in our state, a PBM is going to be treated as a fiduciary. It's questionable whether that's even enforceable, but even if it is, the PBMs have beat you to the punch, because the contract says that if you have participants in any of those states, we don't have to provide services to them. So that's
Yeah.
how badly they want to avoid fiduciary status.
Because you can't be a fiduciary for the employer and also a fiduciary for the shareholders. In the immortal words of Nookie Thompson and Boardwalk Empire, you can't be half a gangster. So we ideally you would use this Quizify quiz, and we have a bunch of other quizzes that go with it. And if you do use a coach, they should teach people how to swim using Quizify in addition to coaching them to jump into the pool. Oh, there you go, right there. You can't be half a gangster. That's why you need a fiduciary PPM. After the curve lessons, we give our quizzes monthly, digestive complications being a good one. That we recommend that these be used for continuing authorization. After all, if you are paying employees to take the weight off, they should be willing at least to learn how to keep the weight off. This is a lot of money. You're asking for very little in return, but whatever you ask for, they should do. So we would end by asking this, and then Mark, I noticed a bunch more questions have popped up, and we do have a couple more minutes. But the ending question is it worth spending $100 to discourage the tire kickers and improve outcomes for a drug that costs $10,000? Because that's what it costs to use Quizify. Coaching is 5 to 10 times that amount. This is much less, and I would hazard a guess, much more effective. Mark, what do we have for the final couple questions? You're muted again.
An attendee here is asking, will Zach share his recommended pre-auth language for GLP-1? So I'm sure Zach can do that. This gentleman is Bill Schmaltz. We'll have Zach reach out to you directly after. Or Zach, did you want to comment on that?
So I mean, I'm not a pharmacist. I don't know precisely what those are. I know that we have stringent criteria in place for that, but I mean, I would not be the right person to enumerate what those criteria are.
Okay. Anything else for Paul or us?
There's a question here that says, can we go back to our PPM and have them check to make sure that anyone on Ozempic is a type 2 diabetic?
Paul?
Yes. Yes.
That's
do
what
it in
you
writing. Do it in
That's what you
writing
do.
and maybe
Yeah.
get a lawyer to help you.
Not just any lawyer.
I'm sorry?
He's not just any lawyer, but you're the leader
Well,
of this
someone who's
particular.
familiar with PBM contracting.
Yeah, right. N equals 1. Okay, so all righty. Well, I think we're all done, and we actually kept most of our audience, which is always very cool. And so thank you for everybody, and thank you especially to our guest panelists. And we will be sending you the materials and a couple other things within the next day or so. Okay, bye everybody.
Thank you.
Thanks, Al.
All right. Thanks, Al.